Hey everyone, we're going to go through chapter 14 right now, which is a pretty straightforward chapter. I'm going to switch to screen sharing mode. Oh, I don't even have it up here. Let me pull it up. Can I screen share this? Sorry, I've never had that happen to me before. Where am I? Here I am. Here it is. Usually it's already there for me. Okay. So we're getting into the respiratory system, which again is very straightforward. There's a little bit of physiology involved, but it's pretty straightforward. These are learning outcomes. They're in your weekly folder or chapter folder already. Let's move into the different parts of the respiratory system chapter. We have functional anatomy and then respiratory physiology. So we're going to start with the functions. So overall functions of the respiratory system. Large surface area for gas exchange. That makes sense. Move air to and from exchange surfaces of the lungs and the respiratory tract. Protect respiratory surfaces. Produce sounds. That's one most people forget. And aid in the sense of smell, right? Our sense of olfaction. So our respiratory system is divided into upper and lower. And the dividing line is this little guy, which will, our trachea here. We're going to get into all of those details in just a little bit. But so you have your nose and nasal cavity. You have the sinuses, which are involved in resonating sound. Your pharynx, your larynx, which is your lower throat. You have the epiglottis, which is this little lid here. Thyroid cartilage, which is the little Adam's apple. And then you get into your trachea, primary, secondary, tertiary bronchi, bronchioles. And the bronchioles branch off into these little alveoli, which are the little bubbles where gas exchange takes place. So let's first talk about our upper respiratory system. Our upper respiratory system warms and humidifies the incoming air, protects that more sensitive lower respiratory tract, reabsorbs any heat or water that's in the outgoing air. The structures include the nasal cavity, the nose, the sinuses, and the pharynx. So that is all our upper respiratory system. The epiglottis here, this little lid, comes down and closes our trachea from any food or water that we're swallowing, which is going to go down this muscular tube right there, which is our esophagus. So this is the division between the upper and lower respiratory system. Lower respiratory system exchanges the gases with the capillary, moves the air to the exchange surfaces. Here we're looking at the larynx, the trachea, the bronchi, the bronchioles, and the alveoli. And there they are. So in our respiratory tract, there are special passageways conducting air from the gas exchange to and from the gas exchange surfaces. There's a conducting portion which just conducts the air into the exchange area. The respiratory portion is where gas exchange occurs. So the respiratory mucosa is lining the conducting portion of the respiratory tract. It's composed of epithelium. It changes in composition depending on where in the respiratory tract you are, but there's also a lamina propria rooting it to the connective tissue below. The epithelium is going to vary along the respiratory tract. As I just said, there's pseudostratified ciliated columnar with mucus cells in the nasal cavity, parts of the pharynx, trachea, bronchi, and bronchioles. And the lamina propria is an areolar connective tissue which supports the respiratory epithelium. There are those ciliated columnar cells helping to basically sweep any mucus and debris up through our respiratory tract back up into our nasal cavity or to our throat so that it can be expelled. Any junk that we breathe in gets trapped there. Let's talk about the respiratory mucosa. It warms the blood vessels, radiating heat into the nasal cavities. It also moistens because of the mucus glands humidifying the air. It also protects the more delicate lower respiratory surfaces from drying out. Cystic fibrosis is a disease that affects the respiratory mucosa. It's an inherited disease, results in the production of sticky, kind of thick mucus, restricts the airflow, increases respiratory infections and damage, and breathing treatments are available to help thin out that mucus. Very sad disorder. Individuals don't live very long with it because it's not really, there's no cure for it. So air passes through the nose. We call them the external nares, which are our nostrils. Then it goes into the nasal vestibule, which is where you have your little nose hairs trapping any airborne particles. The nasal cavity is further up, made of the hard and soft palate, and the internal nares. And then it goes to the pharynx. The pharynx is divided into 3 regions: the nasopharynx, the oropharynx, and the laryngopharynx. The nasopharynx is between the internal nares and the soft palate, so it's very far up there. Pseudostratified ciliated columnar epithelium. Oropharynx is between the soft palate and the tongue, base of the hyoid. This is stratified squamous. And then laryngopharynx is between the hyoid bone and larynx, and that is also stratified squamous. It's stratified squamous in those areas because it shares a function with the digestive tract. There you see it, naso-oro-laryngopharynx. So air passes through the pharynx to the larynx. The larynx is the beginning of the lower respiratory tract. This is where the glottis is located. That's the hole that allows for the opening of air to pass. And then to the trachea, which is also known as our windpipe. You can pause the video here, go back and review. So let's talk about the trachea and the primary bronchi. From the larynx, the air continues into the trachea, and then the trachea is going to branch to form right and left primary bronchi. There you see them, and then the primary bronchi, right and left, are going to branch to form smaller secondary bronchi and tertiary bronchi, so on and so forth, into our lungs, and eventually get to these small little air sacs called alveoli. So the windpipe is about a 1 inch in diameter, has C-shaped cartilage or tracheal cartilage. The posterior wall has a muscle on it, which is going to allow for the expansion and contraction of the trachea. It also allows for the trachea to change shape as food passes down the esophagus. The esophagus is posterior to the trachea, so because that, I'll do it like this, because the tracheal rings are C-shaped, the food can pass through the esophagus, which is just behind the trachea, and still compress the esophagus or the trachea a little bit if you swallowed a big chunk of food or something. If the tracheal rings were, or tracheal cartilage rings were circular, the food wouldn't be able to pass down as easily. So again, the trachea branches to form the right and left primary bronchi. There you can see exactly what I was trying to show you with my hands, which is the C-shaped ring of the tracheal cartilage and our muscular esophagus on the posterior side. Those primary bronchi will branch into smaller tubes called bronchioles, and the bronchioles are lined with smooth muscle. There's less and less cartilage as you move through the lungs. Sympathetic nervous system causes bronchodilation. The parasympathetic nervous system causes bronchoconstriction, which is the contraction or decreased diameter. There you see the bronchiole with the smooth muscle. Asthma is a condition that's an allergic reaction which can cause extreme bronchoconstriction and inflammation and can severely restrict or even stop airflow. Very dangerous. Let's talk about lung anatomy. Your primary bronchi leads into the lungs. The right primary bronchus goes in the right lung, left primary bronchus goes in the left lung. Pretty straightforward. The lungs are cone-shaped, have a concave inferior portion that rests on top of the diaphragm. There's a groove near the superior point called the apex. It's called the hilum. The hilum is the passageway for all of the bronchi and blood vessels coming into the lungs. Each lung is then divided into lobes, superior, middle, and inferior on the right lung, and then just superior and inferior on the left lung. The right and left lungs are not exactly the same because the heart is a little more to the left side of the thoracic cavity, so they're shaped just a little different. The lungs are also divided by fissures, horizontal and oblique fissures on these lungs. So here you see the right lung has a superior, a middle, and an inferior. The left lung just has a superior and inferior. But if you take a look, this left lung extends a little far down compared to our right lung, and that's because right here in our abdominal cavity is our liver, really big organ sitting right there. So surrounding each lung is a pleural cavity. The pleural cavity consists of a parietal pleura and a visceral pleura, just like the pericardial cavity surrounds the heart. Same idea. There you see them. You can pause the video here, go back and answer these 3 questions. Moving on to gas exchange. The alveoli are the tiny air sacs. Each lung has about 150 million of them. They're surrounded by lots and lots of capillaries, and they occur in clusters kind of like grapes. They're surrounded by elastic fibers to allow for expansion and recoil as air moves in and out. Here you see them. Again, primary bronchi is just branching, 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 less and less cartilage, more and more muscle. And then you get to these alveoli, which are clustered around each other like grapes, and lots of capillaries around those areas. So the branches of the pulmonary artery bring deoxygenated blood from the heart to the capillary networks that surround the alveoli. And then gas exchange occurs between the air in the alveoli and the blood in the surrounding capillaries. Then the branches of the pulmonary vein collect all the oxygenated blood to form capillary networks and carry it back to the heart. Very straightforward. The alveolar epithelium is highly specialized. The epithelium lining is very thin to allow for that gas exchange to take place. It's mostly made of simple squamous epithelial tissue. There's other types of cells found in these alveoli as well. There's surfactant secreting cells. Surfactant is an oily secretion that forms like a little coating over the cells, and it helps to reduce surface tension so that they don't implode on themselves. And the alveolar macrophages, which are there to phagocytize or eat any debris, particulates, or anything that could clog up the alveoli. There you see the alveoli and some of the special cells associated with them. The respiratory membrane itself is where oxygen and carbon dioxide move via diffusion. They move across the respiratory membrane, which is very thin, made of that alveolar epithelium, a fused basement membrane, and then the capillary endothelium, which is also simple squamous. Here you see that network. So the alveolar surface, this is the air in the lungs, the alveolar surface, that basement membrane, and then our capillary epithelium, and then the lumen of the capillary where the blood is. You can pause the video here, go back and review. Now let's talk about respiratory physiology. There's really two parts to respiration. There's external expiration, which is getting the air, oxygen into and out of the body. Then you have internal respiration, which is getting the oxygen and carbon dioxide in and out of the tissue cells. So, external respiration includes pulmonary ventilation and gas diffusion. So there's two steps. Physically getting the air in, maintaining alveolar ventilation, movement of air into and out of the alveoli, and then diffusing that gas across that respiratory membrane. So two parts to external respiration. External respiration can be impaired. You can have hypoxia, which is low oxygen levels, or anoxia, which is no oxygen supply. That could lead to tissue death. Very, very uncommon, but still possible. So here you see external respiration involving the gas diffusion into and out of the body, inhale, exhale, and then internal respiration is gas diffusion into and out of the tissues. So let's talk about the role of pressure in pulmonary ventilation. In a closed system like the lungs, any change in volume is going to be related to a change in pressure. If you increase the volume, you're decreasing the pressure, right? If I decrease the volume, then I'm increasing the pressure. It's an inverse relationship between pressure and volume. So take a look here if you're a little bit confused. Here we have some type of closed system. There's a little opening here, just like there's only one opening, right, our nose and mouth, only one opening to our lungs. So if we close this box a little more and we decrease the volume, we're increasing the pressure. There are more little dots in a smaller space, hence increased pressure, decreased volume. Here we are expanding the space, less dots, bigger volume, less pressure. Again, inverse relationship between pressure and volume. So a changing shape of the thoracic cavity is going to change the volume within our lungs and then therefore change the pressure. So by contracting our diaphragm, pushing it down, and moving the rib cage out, we are increasing the volume of our thoracic cavity. What does that do? It decreases the pressure and air comes in. So as we breathe, our diaphragm goes down, our rib cage goes out. That lowers the pressure, which allows air to come into our lungs. So expanding that thoracic cavity will expand the lungs, and the parietal pleura is attached to the thoracic wall. Visceral pleura is attached to the lungs. Pleural fluids, the special bond between them. Atelectasis is the collapse of a lung or part of a lung, and that's when air would enter that pleural cavity. So if there is a puncture, if someone like stabs you in the ribs and it punctures your lung, collapsed lung could result because of that negative pressure that's developing in there. So there you see those boundaries. And as I was getting to, the inhalation is when that volume increases and the pressure inside falls and then air flows in. Exhalation is when the volume decreases, so the pressure inside rises and air is pushed out. Air moves from areas of high pressure to areas of low pressure. And atmospheric pressure is the pressure outside of the lungs. Intrapulmonary pressure is the air pressure inside the lungs, and alveolar pressure is the air pressure in the alveoli. This video here is not linked to the PowerPoint, but you can look at it on our textbook website or simply go to Google or YouTube and type in respiration pressure gradients animation or video, and you will find lots of them at your disposal. So let's look at the changes in alveolar pressure through the ventilation cycle. So in the beginning of ventilation, inhalation, your thoracic cavity is beginning to expand, and so what's happening at your alveoli, the pressure is going down because they're expanding. Then you start to exhale. Your thoracic cavity is getting smaller, so pressure is increasing, and that's what you see here. Increased pressure during exhalation. What about our tidal volume? Our tidal volume is the amount of air exchanged with the environment with every breath we take. In just normal breathing that we're all doing right now, unless you're out of breath for whatever reason, you're doing tidal breathing. It's around 500 milliliters or half a liter that you're breathing in and out every couple of seconds. And so that's what you see here. It takes about 2 seconds to inhale and about 2 seconds to exhale. So you can pause the video here, go back and review. Let's talk about some muscles that are involved in respiration. You have several muscles that are involved in inspiration and a few that are involved in expiration. They're called inspiratory or expiratory muscles. The primary inspiratory muscles during quiet breathing are your diaphragm and external intercostals. Your diaphragm is getting pushed down and your external intercostals are contracting to move your ribs up. There's also accessory inspiratory muscles. These are like your sternocleidomastoid pulling on your clavicle, your scalenes pulling on your clavicle, pectoralis minor pulling on your superior portion of your rib cage to elevate that. There you see some of these muscles. Aren't you glad to be done with muscles? Kind of. There they are again. Now exhalation. There's no primary expiratory muscles because quiet breathing is exhalation is a passive process. Your body naturally does it. Nothing pushes the air out. If you're forcing air out of your body, then you're going to have some accessory muscles helping with that. Things like your internal intercostals, your transverse thoracis, your external and internal obliques, and your rectus abdominis muscles all pushing up and making that thoracic cavity smaller to lower the pressure and push that air out. There are those muscles for you. So let's talk about some volumes and capacities. I mentioned tidal volume already. This is the amount of air that's moved into and out of the lungs during one cycle of quiet breathing. The average is around 500 milliliters. You do have what we call dead space of the lungs. This is the conducting zone. This is where there's actually no gas exchange taking place. The dead zone sounds kind of creepy, but it basically just means that's not the air that's being exchanged. Only 350 of that 500 is actually in the alveoli at that exchange surface. Your inspiratory reserve volume is the maximum amount of air that you can inhale. Your expiratory reserve volume is the maximum amount of air that you can exhale. So if I say take a deep breath, that's your inspiratory reserve volume, and then you deeply exhale everything, push it all out. That's your expiratory reserve volume. The vital capacity is the maximum amount of air that can move into and out of the lungs. That's what I just did, the vital capacity. The maximum amount in, the maximum amount out. Residual volume is something that's never going to change. It's the stuff that's just left over in your lungs even after you've exhaled it all out. There's always going to be a little bit left. And your total lung capacity is your vital capacity plus that residual volume. So it's everything that can fit in your lungs. So here you see some of these volumes in an adult male. Tidal volume up and down about 500. Then we ask him to breathe out as much as he can, about 1,000. Go back to tidal volume. Now inhale deeply, And then exhale deeply. That's your vital capacity. Notice the residual volume never changes. It's always there, about 1200, and then return back to tidal volume. You can pause here, go back and review. Let's talk about gas diffusion throughout the body. Oxygen moves from where there's more oxygen to where there's less oxygen. Just like everything else, it moves from high to low concentration. Same thing with carbon dioxide. High concentration to low concentration. There you see it. In external respiration, the oxygen is leaving the alveoli, going into the blood. Carbon dioxide is leaving the blood, going into the alveoli. In internal respiration, the opposite's happening. From the blood, it's going from oxygen to the interstitial fluid, and carbon dioxide is going from the interstitial fluid into the blood. So, blood in the pulmonary arteries has relatively low oxygen and high carbon dioxide content compared to the alveoli. So, oxygen tends to flow from the alveoli into the capillary. Carbon dioxide tends to flow from the capillary into the alveoli. Just like I just showed you in that last picture, right? In internal respiration, the cells in the tissues use oxygen and give off carbon dioxide through their respiratory processes. So oxygen levels are low in the interstitial fluid and carbon dioxide levels are relatively high. So oxygen tends to flow from the capillary into the interstitial fluid and carbon dioxide tends to flow from the interstitial fluid into the capillaries. Again, this is a video. You can search for it on Google or YouTube or look on your textbook website, carbon dioxide and oxygen transport in the respiratory tract. There's the same picture I showed you earlier. Oxygen is picked up by those pulmonary capillaries and it's bound to hemoglobin on the red blood cells. It forms something called oxyhemoglobin in this little reaction right here. In the systemic capillaries, the process is reversed and oxyhemoglobin is broken down into hemoglobin and oxygen. Carbon dioxide is picked up in the systemic capillaries and then it's carried in the blood in one of three ways. It can be dissolved in the blood plasma, it can be bound to hemoglobin, it's called carbamine hemoglobin, or it can be converted into carbonic acid, which is when carbon dioxide and water interact to create carbonic acid. Carbonic acid is going to dissociate into a bicarbonate ion and a hydrogen ion. The bicarbonate is exchanged in the plasma for a chloride ion, and this is called a chloride shift. You'll see the picture, it'll make more sense. In the pulmonary capillaries, the whole process is reversed. The bicarbonate is exchanged for chloride back into the red blood cells. The bicarbonate combines with hydrogen to form carbonic acid. Carbonic acid reforms into carbon dioxide and water, and then the carbon dioxide can diffuse out of the alveoli and be exhaled. So here's the whole process. You have oxygen pickup. Oxygen's coming from the alveoli into the blood, either dissolving in the blood, reacting with hemoglobin to form oxyhemoglobin. Here it's going to go into our peripheral tissues and be absorbed. And then carbon dioxide is going to be exhaled or released from those peripheral tissues and go into the blood. From here, it can either dissolve in the blood, it can form carbamine hemoglobin or bind to a hemoglobin molecule, or it can form bicarbonate. Bicarbonate will dissociate into, or can form carbonic acid. Carbonic acid is going to dissociate into bicarbonate and hydrogen ion, and so that all of these hydrogen ions don't just build up inside of the red blood cell, the bicarbonate will leave and chloride will come in. That's the chloride shift. Then back at the lungs, we have the opposite happening. Our bicarbonate is coming back in, our chloride is being shifted back out, our bicarbonate is combining with the hydrogen ion to form carbonic acid, converted back into carbon dioxide. Our carbamine hemoglobin is losing the hemoglobin, converted back to carbon dioxide, and the carbon dioxide from the blood is being transported back out into the alveoli as well. Then the whole process starts again. You can pause the video here and go back and review. Let's talk about how the respiratory system is controlled. There's subconscious control of the respiratory done by the medulla oblongata and the pons. The medulla oblongata has what's called the DRG and the VRG. The DRG is the dorsal respiratory group. This controls the inspiratory center, which is controlling your external intercostals and your diaphragm, functioning with every breath you take. The ventral respiratory group is involved in both inspiratory and expiratory, and it's usually only activated when you have some abnormal oxygen demands, like increased or decreased demands. The subconscious control is also regulated through the pons. The pons has respiratory centers that adjust the rate that is set by the medulla oblongata. So your pons is overriding your medulla oblongata, in terms of respiratory rate control. So in quiet breathing, we can take a look here in any little part. The diaphragm and external intercostals contract, inhalation occurs. The neurons in the DRG become inactive. Then the diaphragm and intercostal muscles relax, passive exhalation. Then DRG is stimulated. They contract, then they relax, and then you exhale, and then they are stimulated, and they contract, etc., etc. That's all during quiet breathing. But during forced breathing, say you're taking deep breaths or you're exercising, increased activity of the DRG is going to say, whoa, we have more than we can handle here. We need the VRG to activate some of our accessory muscles. So the VRG is going to be activated. All of our inspiratory muscles are going to jump on board. And then our DRG and inspiratory center, the VRG, are inhibited, and expiratory centers are activated, and then we exhale. So how do we maintain homeostasis? Usually carbon dioxide levels are the trigger for breathing. So our body doesn't care so much about oxygen. I mean, obviously it does, but the big player in respiratory rates is carbon dioxide. So with increased carbon dioxide levels, hypercapnia, you're going to get a lower it's going to be caused by a lower respiration rate. So that situation is going to stimulate chemoreceptors, and your body's going to respond by increasing your respiration rate. That makes sense. If you're not breathing enough, all that carbon dioxide is not getting exhaled, which means you have to increase your breathing so you can get rid of that carbon dioxide. As we'll see later, carbon dioxide is also related to overall pH in the body. So if you have too much carbon dioxide, you could also have an acidic state going on in your body. If you have hypocapnia, low carbon dioxide levels, that could be caused by hyperventilation, where you're breathing too fast and have a very shallow depth of breathing. Your body's going to decrease the respiration rate. So here you see the overall process. You have homeostasis, normal CO2 levels. All of a sudden, you have hypercapnia. So you have increased carbon dioxide levels in your blood. Your chemoreceptors are going to sense that. You have a decreased pH, etc. So your respiratory centers are going to be stimulated, and you're going to have an increased respiration rate. Homeostasis is restored. You have decreased carbon dioxide levels, hypocapnia. This is going to inhibit those chemoreceptors. You're going to inhibit your respiratory muscles. You're going to slow everything down, decrease respiration rate, get your carbon dioxide back to normal levels. A shallow water blackout. This is your body's trigger to breathe. The body's trigger to breathe is high carbon dioxide. So when you have high carbon dioxide in your body, that's going to tell your body to exhale and inhale. Hyperventilating before going underwater is going to cause decreased carbon dioxide. So levels of oxygen can actually drop enough to cause fainting or blackout before levels of carbon dioxide even rise enough to get you the urge to breathe. So hyperventilating before you go underwater is like not a good idea, because again, you're going to have too much oxygen there to balance off that carbon dioxide buildup. You don't want to offset that balance of oxygen and carbon dioxide by doing something like that. You can pause the video here, go back and review. Let's talk about some clinical respiratory terms. COPD, chronic obstructive pulmonary disease. It's a general term for a series of disorders that restrict airflow, something like asthma, chronic bronchitis, emphysema, all characterized in the COPD family. Asthma's extreme sensitivity or irritation. The response is a constricted airway, increased mucus production, and inflammation. The triggers could include allergies, toxins, exercise, cold weather, and stress. Chronic bronchitis is the long-term inflammation of the bronchial lining. Could be caused by an overproduction of mucus, clogging the airways. Cigarette smoking can lead to it, often leads to chronic bacterial infection. Subsequent heart failure may cause edema and swelling. Low oxygen levels give your skin like a bluish tint, and that leads to the term blue bloaters, people that are swollen and kind of bluish looking, clinically speaking. Finally, emphysema, which is chronic progressive condition. The alveoli gradually expand and merge with adjacent alveoli. So ultimately, there's little elastic connective tissue there for recoil. So you're losing respiratory surface area, and that's going to cause shortness of breath. Enlarged and overspanning lungs are still there, your lung tissue can still expand, but those alveoli and bronchioles can't. Heavy breathing, pink tint to the skin has led to the term pink puffers instead of blue bloaters. Again, clinical terms used to characterize patients. Lung cancer accounts for about 12% of new cancers in both men and women. 50% of them die within a year of diagnosis. 80 to 90% are a direct result of cigarette smoking, including secondhand smoke. Just don't do it. Non-smoker living with a smoker has a 20 to 30% chance of developing lung cancer. That's just crazy. Stuff that you're doing to your own body. Anyways, effects of aging. As with everything, it slows down and gets worse. Skeletal system, connective tissues become less elastic and less flexible. Over age 50, there's going to be some degree of emphysema just from normal wear and tear and breathing stuff in all the time. Loss of elastic connective tissues. Decline in respiratory performance is inevitable, but it is greatly influenced by smoking. Last 3 questions of the chapter. You could stop the video here and answer these 3 questions. I hope this video helped you. This chapter is very straightforward, as I said, nothing too tricky about it, and just a little bit of physics with the pressure and volume thing. Hopefully doesn't blow your mind too much. Let me know if it does. Let me know if you need help, and happy studying. See you.